Recording in progress. Hey, happy Friday, folks. This is Tracy Lawrence for the Good Kids Club podcast, and I am so excited today. Our topic is breathing is fundamental. And as a living human being, I really love to breathe, don't you? And I said in the intro to this session that it's something that we take for granted because all living things need to breathe, right? We need oxygen in order to live, to survive, for our cells to fix themselves. So it's an extremely important process, and we take it for granted because most of us do it automatically without thinking about it. But things can happen to us that can deprive us of our ability to breathe freely, and it impacts our ability to conduct our lives and to be independent and to enjoy this marvelous gift that we are given. So today, my returning guest, my good friend Rose Rohloff, is going to join us to talk about this very important topic because she is actually helping someone who is having difficulty enjoying this very fundamental right of being able to breathe freely. So I'm going to ask Rose to, for those who haven't had the privilege of meeting her before, to introduce herself, talk about, excuse me, what she is, who she is, what she does, and then we're going to talk about helping our the people in our lives to be able to breathe more freely. And of course, for good kids, this is a very important topic as well. We have aging loved ones, and we want to be able to help them and help ourselves to be able to breathe. So, Rose, tell the good kids about you.
As a quick synopsis, because I have said this before, so I don't want to be redundant for listeners. I started off as a registered nurse when I was 19, a charge nurse when I was 20. I worked critical care, SICU, MICU. I did building of clinical documentation systems, the first perioperative business intelligence suite in the industry. I've done healthcare consulting on multi-million-dollar engagements. So I've got a very widespread background. And I've coined the term patient championing because we now need champions at our bedside to help with care. And another thing that we're instituting is a service. And as I walk you through the use case scenario of what we've encountered this week, it will give to light why it is so imperative. And it's reviewing hospital records, getting them digitized, getting them corrected, and doing your own personal health record. And that's a service we're doing because everybody needs it. People don't know they need it. They don't know to ask for it. And there's nobody there doing it for them. So I want to walk you through, this is kind of a detailed use case scenario, but from front to end, it will bring to light exactly what is going on and why these solutions are so needed. And you have to champion your own care.
Yes.
And for full disclosure, I am with permission saying this de-identified. Obviously, I'm not going to blast my friend's name out, but she's giving me permission, de-identified, to provide her use case for education.
Sure.
So she was not being followed with a patient champion. She was in and out of the hospital. She's got respiratory issues with periodic AFib. AFib is not her primary condition, but it was paradoxical. It was infrequent. Mm-hmm. So her primary issue is a respiratory issue.
Okay, so all right, I want to stop you for just a moment because there are people who don't know what that means. So respiratory refers to the lungs?
Correct. Absolutely.
And AFib has to do with irregular heartbeat?
Correct. I'm sorry. Yes. You know me, we got to stop and we got to clarify
yes,
acronyms.
Yeah. So I'm for the lay people who watch this, I want them to understand like what you're talking about because I never want anybody to feel overwhelmed with information. So, all right.
That's perfect. Thank you.
You're
so
welcome.
atrial fibrillation for her heart but again, not her primary issue. It's very infrequent.
Mm-hmm.
But her primary problem is a breathing problem. She was having some, they don't know, but they're thinking maybe a little fibrosis with her lungs.
Okay. And just
So
so you
anyway,
know, the fibrosis is a condition that causes the tissue in the lungs to stiffen.
right. And what's happening is you don't get the proper lung expansion. And going to acronyms, this is a good time to also do a clarification because we're misinforming the public. When they say COPD, that means chronic obstructive pulmonary disease. But that means it's a grouping of diseases.
Mm-hmm.
It doesn't just mean emphysema, because you see ads on TV, they're like, use this drug for COPD, but don't use it if you have asthma. And it's like, asthma is COPD. You've got asthma, chronic bronchitis, emphysema, general fibrosis, people that have been impacted by asbestos. Chronic obstructive pulmonary disease is a grouping. And again, I think the drug companies on TV are misinforming people. They're not properly educating.
Right. They're
So that's a
advertising.
great place to start.
Yeah.
Yes.
They're busy creating need, but they're not educating.
Yes. Oh, take this drug for COPD, except for if you have asthma.
Yeah, as soon as you said it, I was just like, oh crap, really? Yeah, I'm not, I don't pay a lot of attention to those commercials any longer because
They're
I
that
see what
bad.
they're doing and they give me a headache. So,
Yes. So going back to my friend, the first thing we did was, now she's on continuous oxygen.
oh,
And I want to do a very clear distinction of education as well, of oxygenation, meaning bringing my oxygen in. Then there's the issue of exchange, meaning I'm converting oxygen to CO2,
mm-hmm,
expelling, getting rid of the CO2, and then what's called desaturation.
mm-hmm,
Desaturation means, people have heard of hemoglobin. Hemoglobin is your truck. It's driving around your body to deliver the oxygen where it's needed so it can be used.
right,
So desaturation is your heme isn't saturated with oxygen. So when they put the pulse oximeter on the finger, when they say the PSO2, that's your saturation. Is the heme full of oxygen to be put on the truck to be delivered to your body organs and skin tissue to be used?
right. And and it's used for cellular repair, correct?
Well, it's used for functioning. Absolute, just functioning. Your cells, your organs need oxygen to function. So it's not even regeneration, it's for using. My heart needs, my muscle needs oxygen to operate. When you're exercising difficult and you're breathing harder, and then you have buildup of lactic acid because you've been working out.
Right.
Okay, so saturation is very important to understand, is different than lack of oxygenation.
Right.
These are huge, impactful things. So I want to walk you through the situation.
Okay. But I have a question.
Sure.
How is the oxygen being delivered? Is it like
The
just
hemoglobin,
no. I mean your friend's
nasal
oxygen.
cannula. Yep.
Okay, so is it that those
Nasal
little
cannula.
things that go up in your nose and a little hose goes around your head and it's
Correct.
okay.
Correct. But when you said being delivered, I'm sorry, it was like it gets delivered by your hemoglobin.
Yeah, no, I mean like how is she getting the oxygen?
Yes.
That's
So the oxygen is coming in via nasal cannula.
okay.
Okay, so this is going to be very convoluted, so I'm going to try to really break it down.
Okay.
So I got a hold of her because she really wasn't being followed up at all. She was not being followed up by a pulmonary specialist. No pulmonologist was following her. This is also important to understand. So a general doctor was doing whatever he was doing, but there was no proper follow-up. There was no care coordination. There was no good care planning going on.
Okay, and she's in the hospital.
No, she was in
Okay.
rehab at this point.
Ah.
Hospitalization. So
Okay.
now I got involved.
Okay.
So history of, we were getting, it was pneumonia, you got double pneumonia, but then all of a sudden it's like, well, you had pulmonary embolisms, this, that, and the other. And it's like, look, guys, what is going on? So I looked at her electronic medical record and I said, the first thing we're going to do is we're going to digitize it, get it organized. We're going to get an electronic personal health record that is comprehensive done on you. And when I'm reviewing her electronic medical record, one of the things they put on there is that she was hypoosmolality with hyponatremia. That means she would have been drinking gallons of water a day to dilute out her sodium. And I'm going, where did this come from? And what does that have to do with it? Because when I looked at her sodium, it was normal. And then I looked, okay, you got hyponatremia as a diagnosis. And then right below it, it had low sodium diet. And I'm going, none of this makes sense. Your sodium is normal. Why are they saying your diagnosis is you've been drinking gallons of water a day and your sodium is diluted out? That's what the hypoosmolality means with hyponatremia.
Okay.
So it's like, again, people don't understand. Nobody's reviewing the electronic medical records to understand that it's bad data. And supposedly, this is supposed to be your history that doctors are supposed to be coordinating off of, and your history for understanding of diagnosing and treatments. So, that's how bad they are because nobody's reviewing the records.
Yeah. No. Okay. So she's still in the rehab facility?
No. Let me walk you all the way through. Okay. Right. I picked her up, took her to the residence so I could take care of her.
Okay.
She's on continuous O2 machine.
Okay.
So again, why I wanted to make a distinction of oxygenation versus saturation. Her normal oxygen saturation when she was resting was around like 96%. That's good. But when she would get up and move, it was dropping to below 85%.
Yeah, that's bad.
Again, this is important to understand the concept of desaturating. So when I use that term, that's what it means. When she's moving, she's desaturating. So again, it's not lack of oxygenation, it's desaturating. Okay. And again, we're not educating people on when they're sent home on oxygen, the difference between all of this and what it means. So bottom line is we reorganized her meds, her protocols. I'm not going to go into in depth of all of that because I don't want this to turn it into a 2-hour presentation. So in 4 days, we got her from 5 liters down to 3 liters at resting, with her saturation staying at 96%. Because again, nobody was doing tolerance testing on her at all, none. And what people don't understand is when you're left on 100% pure oxygen for a long period of time, it can actually cause damage. And again, people aren't aware of this. Why should they be? And nobody was doing tolerance testing on her of saying, look, at rest, we got you down to 3 liters of O2 and we kept your saturation up. I also got her into proper breathing exercises because we needed to strengthen and wake up her chest muscles. Because her chest muscles needed strengthening to learn how to breathe again.
Wow.
Correct her posture so she wasn't slumped in and panting. Still doing some coughing and deep breathing to make sure there's no what's called atelectasis, so she has proper exchanging going on. All of this stuff. And again, I don't want to get too detailed, but the bottom line is she was progressing within 4 days. She goes, I feel great. Well, okay. She had an instance of a bout of AFib, atrial fibrillation. Again, she knows her body. She goes, I'm in AFib right now. And checked her heart rate, checked her saturations, got her vitals. So I called 911 because I'm like, look, we don't have a doctor. There's nobody following her. We got to get her in because she's on anticoagulants. And we got to make sure that she's not going to be in sustained AFib because she had a history of PE. We don't want her to get clots. We don't want her to have a heart attack, etc.
Right. And just again, I'm sorry, so people understand, when you have AFib, your heart isn't pushing all of the blood in the chambers out.
Oh, what happens is think about it like a little bit of a quivering. So
Yes.
blood can do a little bit of churning and it may cause a little clotting.
Right. And
So
if you have, right.
yeah.
So and a clot in the heart is a heart attack.
No.
No?
A chamber. No, be careful of that. It's
Okay.
in the chambers. So when clotting could occur because you're not pushing and it's not flowing.
Mm-hmm.
So if it gets a little bit of churning, it may create a couple little clots in the chambers.
Mm-hmm.
Now, a heart attack is a clot gets into your vessel and prevents the oxygenated blood from being used in the muscle.
Okay.
Yeah.
Great to know. So anticoagulants keep the blood from clotting, correct?
Correct.
Okay.
Correct.
Okay.
Yep.
All right. So it just want to kind of,
Yep, absolutely.
paint the picture.
Absolutely. And with somebody who's got some not running around all the time because of her breathing issues, you don't want her to create blood clots in her legs.
Right.
And again.
Oh, and then you mentioned PEs.
Yep, pulmonary
embolism.
So a pulmonary embolism is the same thing like a heart. Let's break it down. So a small clot that gets in the vessel to your heart, that can cause angina, which is chest pain, because my heart's not getting oxygenated blood. The difference between angina and a heart attack means there's been enough deprivation of oxygenated blood that there's cell damage, cell death. That's the difference between angina, chest pain, and a heart attack. Okay?
Mm-hmm.
The same thing with your lungs. If I get a small clot in the tiny vessels of my lungs, that's called a pulmonary embolism. And again, a PE could be fat. It could be blood clot. It could be an air bubble.
Oh.
And this is important because as I go through the story, people are not understanding that PEs are more than just a small blood clot.
Okay.
Anything that's interfering with oxygenated blood going through that vessel to be used by the muscle.
Okay.
So.
Okay, I'm glad we're having this conversation.
No, this is excellent knowledge for people. Excellent knowledge for people. So anyways, fast forward through the ER visit, we got a great doctor. I will give him a plug, Dr. Stoner in Halifax Hospital. It turns out he's retired. He goes, I just love being a doctor.
Oh.
He used to be cardiovascular and he was the chief medical officer. So we lucked out getting a great doctor. So anyways, the good thing is we found out that her liver function tests were way sky high. And again, I don't want to go into too much detail on this, but one of her lab values was 30 and it skyrocketed up to 259. This is like, this is bad. We need to monitor this, what's going on. So in talking with the doctor, the great thing was, is he said, look, you're recovering. You know, we do see they're on the AFib. So we need to get you in to be seen, you know, for that, this, that, and the other thing. And he says, we need to coordinate with your primary care doctor. And I'm like, wow, I love it. An ER doc that says, we really want to get a primary care doctor involved so you have good care coverage and care planning and care coordination. That was wonderful.
That's unusual.
But again, he's a retired old-fashioned doc who used to be a chief medical officer. Now, this was the other thing. He said, based on your breathing, you know, okay, you know what, I think you're right. And I says, wait a minute, time out. I said, this is her saturation when she's at rest. And what we did was we moved her from 5 to 3 at rest, but we still have to bump up her O2 to 4 liters when she's walking around because she's still desaturating to 86. He goes, oh, based on that knowledge, I'm going to change my opinion. We need to get you followed by a pulmonologist. But again, if I hadn't relayed that information, it was an additional piece of the pie he needed to know.
Mm-hmm.
And he was like, wow, thank you for telling me that. Now I have more comprehensive information by which to make a judgment call.
That's
and again,
awesome.
We have to partner with the clinicians. We have to feed them as much because they may not ask the exact correct question.
Right.
So it's got to be a partnership of give them as much detailed information as possible, because again, they may be a limited time or they may not have asked that exact question. So anyways, get her discharged, has a great day. She's progressing. 2 days later, she's like, I feel stuffed up. Okay, that's an indication. She goes, I feel stuffed up. And her saturation dropped. So we're trying to get her into a pulmonologist, trying to get her in, try to get her in. We're seeing new patients in February or April. This is the beginning of December. You want us to wait 2 to 4 months to make an appointment with you. And we were told this by multiple offices. After I'm relaying the situation, I'm like, do you understand? She desaturated to such a level that it would be classified as respiratory arrest range. She needs to be seen. And the office staff was horrid. We never got to talk to the doctor. The office staff who are not clinical call us back in April. Oh, by the way, do you want us to put her records into her file? I'm like, why do I care if you make a file on her that you can't see her until April? Unacceptable. No. So anyways, again, we want to avoid ER calls. We want to avoid hospitalizations. So fast forward to the end of the day, you know, she's still okay at rest. So we're not getting her up and about. She develops a severe bloody nose. So again, a bloody nose on itself shouldn't be a big deal. But she's been on hydration O2, but you got to keep it moisture so they don't dry out. She's never had a bloody nose before. And I know that her liver function tests were elevated and she's on a blood thinner. It's a symptom, not the problem. I call 911 because we got to get her transported in. I'm not going to throw her in the car because again, I'm like, I need coags on her. I don't know what's going on with her bleeding.
What's
I don't know
whoa,
if
whoa, whoa.
maybe her hemoglobin's low and that's why she's desaturating all of a sudden. I don't
Co-eggs?
know. I need labs.
Co-eggs?
Oh, coags, her bleeding factors. Because
Okay.
again, liver impacts your bleeding factors called PT and PTT. And she's on a drug that I know causes lack of clotting.
Right. Anticoagulants, yes.
So I know she needs labs now.
Mm.
So we've got to call 911 because I can't call a doctor to say, we need labs now. So anyways, the fire department has to respond with paramedics.
Okay.
And an ambulance has to be called. Again, I let them know my background, and ironically, the same team that had showed up the day before was the same team that came out to respond. And I thought, oh, this is a good thing. So they showed up and the attitude was, why are you calling us for a bloody nose? You know that you can get a bloody nose on oxygen if your nasal passages dry out. And I'm like, not what you want to walk in and respond to me with. I'm like, look at her machine. It has moisture in it. I said, I know her liver function tests are through the ceiling. She needs her coags checked. This is a symptom, not the problem. And she's desaturating. So of course, they're paramedics. They can't do anything more than what I've already been doing. Mm-hmm. And unfortunately, they have to sit there until the ambulance can arrive. So I understand. It's like they don't like hypochondriacs. They don't like to sit there. And I mean, basically, there was nothing for them to do except wait for the ambulance.
Right. So they feel like they're wasting their time. So they're taking
it. And to an extent, they were, because again, I just need an ambulance. I need transport.
Right.
But it was the attitude of, lady, this is a nosebleed. And they weren't understanding, no, guys. And so one of the paramedics, started listening. But the other one, the ambulance arrived. Now she's on continuous oxygen. It's clearly seen. I explained she desaturates rapidly on O2. So to switch her over to the O2 tank, you're supposed to out, in. The ambulance driver says, oh, I know respiratory patients or heart patients. And you know what? You don't have club fingers and you're not blue. So it's not a big deal. And I went, excuse me, what? Timeout. Excuse me? And then she's taking her time. They took her off of the O2 and probably took well over a minute to transfer, to get her on the new oxygen. And the patient is sitting there continuously monitoring her saturation going, I'm down to 78.
Oh, jeez.
And she's panicking. And one of the paramedics looks at me and says, oh, does she have anxiety? And I blew a little gasket.
Oh, man.
And I went, she is hypoxic. Get the O2 on now. And the paramedic driver's like, I'm getting there.
Oh,
and then,
lovely.
And again, in not being followed by medical people, the average person doesn't know what's going on or the impact of saying, when a person is deprived of oxygen, they get anxious, they get confused. And again, this is a symptom. She doesn't have anxiety. You should have been immediately going, she's hypoxic, guys. Get the O2 on her. So the ambulance driver, I couldn't ride in the ambulance, so I followed it. By the time we arrive into the ER, I happened to be standing there, and they very condescendingly looked at the admitting person in the ER and went, "It's a nosebleed."
It's 1 o'clock.
And I just went, "No, the nosebleed is a symptom. This is a patient who is severely desaturating with elevated liver function test. We need to rule out if she is in DIC, if there's liver failure." And it was like, I couldn't believe the ambulance people said that. And then the driver, who was very condescending, that didn't get her on the O2 right away. I found out that when she was checking her pulse oximeter, she was recording it as 100%. She put the pulse oximeter on the patient's cartilage of her ear. And I'm going, why would she test that on the cartilage? Keep it on her finger. That's how it's being monitored. That's how you know her baseline with any changes. And if you were ever to put it on the ear, you put it on the tissue. You don't put it on the cartilage. And how are you getting 100% reading when she has never, ever, ever been at 100%? So just
Rose,
so you know,
I'm sorry, Rose. You used a term DIC.
Oh, I don't want to go too far into it. Just
Okay.
we need to rule out issues. Okay. I don't want to get too deep in the mud because I want to finish the story.
Okay, fair enough.
The bottom line is I contacted the chief of the fire department to talk to him.
Good.
I contacted the county and talked to the supervisor over the ambulance drivers.
Good.
About all of this because it was horrific. And again, I understand they have to deal with some people that are hypochondriacs.
Of course.
They have to deal with scut calls.
Yeah.
But and somebody says, this is my background. Oh, by the way, the patient is a retired nurse as well. And we're giving you the rundown. You listen to us because we're higher trained than you.
Absolutely.
So while we're in the ER, we got a great ER doc. She's like, yes, we're going to get you admitted. She needed to be tuned up. I'm not going to say that it was an emergency hospitalization, but she needed a tune up. Okay. Before she is in a full blown, we need to get her in for critical care.
Yes.
So the nurses in the ER never washed their hands. And I know they didn't because I washed my hands and there was no paper towel to dry it. Because I wanted to wash my hands like you're supposed to with good protocol and then grab a paper towel with motion and shut the water off with the paper towel.
Sure.
No paper towel in the room. And they're like, well, they use the hand sanitizer. I'm like, I have yet to see them pump hand sanitizer and rub their hands walking in or out. The ER nurse, not a single nurse on the ER or on the floor ever listened to her lungs. They have no idea what a baseline is. I was educating them on, I will find, we did get one good nurse on the floor and I'll tell you her background. So just so you know, no assessments whatsoever. None, zero, zilch. Never touched the patient at all. Except to try to start an IV and blow her veins all over the place because they don't know how to start IVs. They're not trained. They don't know how to start IVs.
Oh, man.
So we had a good ER doctor, all right? She came in and she ordered an ultrasound of the legs to rule out if she had any clots in her legs. I'm like, wonderful. That's great. I think that's a great precaution. Wonderful tech. This is the story that made me want to cry. She shared with us, She has a 6-year-old daughter with severe asthma. In and out of the hospital ER, had to be intubated many times. It took her 1 year to get her daughter in to see a pulmonologist. 1 year. And this is a 6-year-old in and out of the ER, had to be intubated several times.
Okay. And this is this is in Florida.
Yes.
Okay.
But again, the problems I'm talking about aren't isolated to individual areas. The poor quality of care standard is across the country.
Okay. Now, Rose, I sincerely appreciate this story and this perspective. What I'd like to know is what's your friend's status now, and I would like to give listeners some guidance in how they can be be prepared and how they can
Right.
overcome
Right.
these issues
Two
in
things
their
I
own
have
lives.
two things I have to relay. So again, I did tolerance testing with her on the unit. We got a great pulmonologist to follow her. And I'm going, why is she still on 5 liters? And he looked at us and he goes, you guys are RNs, turn it down yourself as long as your saturation is good. I'm like, great, we'll do it ourselves. And then I had to keep reporting to the nurses because they weren't doing any tolerance testing on her. And I said, I want you to coordinate your bladder when you have to get up to go to the bathroom, when the nurses are going to come in and change your IV, or when they're going to come in to do the vitals, so they can test your saturation while you're up and moving, while they're in the room. Because otherwise you're going to call them and say, I've got to go to the bathroom. And you're going to sit there for 20, 30 minutes, or you're going to get up on your own and you're not going to be monitored. I said, you coordinate when you know the nurses are going to come in. And then the second thing is they discontinued her IV. They didn't disconnect the IV. They just shut the pump off. And I'm going, that's going to clot off. There's no fluid running. Why did they leave it attached? They just shut the pump off. So then the nurse comes in and I go, her IV is discontinued. And she goes, oh, well, let me go check the order. And I go, the pump's not even running. It's going to clot off. She goes, well, we flush it once a shift. It was a continuous IV. How do you know it was flushed? So then this is what she did. There's a little tube that sits here, and then you've got the bigger tube, and there's a connection point here. Now, an IV is supposed to be sterile. It's sterile. It's going directly into your vein. She put the clamp on it, disconnected it, and then had the patient get up and go on the commode. It was dangling. The tubing was open to the air. It was no longer a closed system.
Right.
And it was dragging across the patient's dirty gown while she was on the commode. And I said, you just opened up her sterile environment. You didn't put on a cap. And she goes, oh, well, I'm going to cap it. You opened up a closed sterile system to be open. And she goes, well, I'm going to clean it. So she took an alcohol wipe and just wiped it with an alcohol wipe. Didn't even let it dry. And then supposedly put on a sterile syringe with saline to flush it. And then she grabbed a cap, which is supposed to be dirty or unsterile on the outside, sterile on the inside. And she was holding it with her dirty gloves. And I said, you just contaminated the sterile end of the cap with your dirty gloves. Have you never heard of sterile to sterile? This was a nurse who's been a nurse for 22 years. So the positive side was is she was lucky enough to get a traveling nurse who was from Puerto Rico. And the nurse from Puerto Rico says, in there, we had to take care of 25 patients. I only have 6. She showed up 20 minutes before her shift to read all of her patients' charts before the shift started. So she could look at the nurses and go, just tell me what's different. I have never heard of a nurse showing up 20 minutes before the shift, not clocked in, on her own, to read her patients' charts before the shift started so she knew who they were, what was going on with them. So when she went into report for change of shift, she's like, just tell me what's different.
That's awesome. Okay, so
You won't see that. Yeah. So
Rose.
now let's open it up. Yeah.
Okay, so and that's fabulous. Is your friend out of the hospital?
She's being discharged today.
Great. How's she feeling?
Great.
Awesome.
And it's like, I want her out of there as fast as possible.
Yes. Now, when she's going to go home?
To here, correct. So
Okay.
I'm going to do one-on-one with her.
Oh, great. Okay.
And her discharge, I asked the doctor to write standing orders for labs that we can follow up on.
Great.
Because otherwise we're going to have to call them to try to get labs, and they'll be like, come on in. And I'm like, no, on the discharge planning, get preset orders, open orders, so we can get her labs followed up on.
Okay. All right. Now, for families who find themselves in this kind of situation where they have a loved one who, now, of course, they're not going to know as much about someone's care as you will, right?
Right.
What can they do? What advice can you give them to empower them to be able to advocate for them? Is there someone from the outside that they should hire? Is there, who can they go to? How can they create a team?
Right.
Right. To help them to be able to navigate this, because as we know, all right, we are in an environment right now where, and all of us have seen this. I mean, when my husband was in the hospital, I had to yell at a nurse for drawing blood through my husband's PICC line without sterilizing it first. Okay, so I totally get that, but I'm also not a nurse. I only play one on TV. So
right. But you had to educate yourself. The number
right.
one thing is question everything. Patients are dying from hospital-acquired infections and hospital-acquired conditions, and
right.
it's never being recorded.
Right.
And again, I don't want to get into politics and this, that, and the other thing.
Right.
But the numbers being reported, people, because I'm witnessing it firsthand, people are dying from hospital-acquired infections and hospital-acquired conditions. So number one, it's abysmal that advocates, or I call them patient champions, aren't being allowed at the bedside to stop all of these errors.
Right.
That's number one. Fight and say, no, I'm going to be at the bedside legally. You shouldn't be able to stop me. And at the least, get a nanny cam. And you have a nanny cam sitting there watching. And if they say, well, it's violation of HIPAA, no, we are transmitting their data to the legal power of attorney or the legal right of the family. Right. And feel free to put it in the record.
Right.
Get your advanced directives and your power of attorneys lined up ahead of time.
Yes, that's where I was going. It's very important for families to have that paperwork, because if you have a document, a legally signed document where your loved one has appointed you to represent them, then you have standing.
Yes. And as soon as you go in, you make sure those people are on the record, that they can call at any time, give me the information, because they don't do that. And then it's like, I'm sorry, I can't give you the patient's information.
Right. And at least if you have that medical power of attorney or healthcare proxy, whatever it's called in the state that you live in, you will at least have standing to be able to talk to the people in the medical establishment at whatever facility your loved one is at, so that you can have those conversations, you can ask questions, and if they're unable to ask questions, you keep putting the pressure on until you can get answers.
Right.
And so, all right, so let's say you have a loved one in the hospital or in a facility, and you've asked the questions, and you're being given the stiff arm, even if you have the documentation, or the answers they're giving you don't sound right. What can somebody do in order to move the needle, to be able to get better answers, or to change an approach that's being used on your loved one?
You know, sadly, number one, you've got to educate yourself on the conditions yourself. You have to know what labs, based off of condition or medications, what labs should they be monitoring? Because right now it's the gunshot approach, and they may or may not do the right ones. And you got to get a patient champion. You got to hook into somebody who's got a medical background then at that point and say, I need a patient champion. You've got to do your own personal health records, do your own trending. So again, I'm doing these HC aware presentations to walk people through all of this and to educate them. And also too, as we started this new service of get your documentation digitized, get it organized, get it reviewed. And people don't understand how imperative that is. Because like I said, in reviewing my friend's record, who's a retired nurse, the diagnosis was so off. It's like, where are you guys coming up with this stuff? and in the summary, they probably had her listed, I think, with 10 different ICD code diagnoses. And again, ICD codes are the WHO codes. They're the World Health Organization coding system. And there's something to the tune of 68,000 codes. And they probably had 10 different ones associated with one admission. And I'm going, where are you guys coming up with half of these? And some of it was like, you're double billing.
Because that could never happen, could it?
I may have 68,000 codes for one diagnosis. Let's say congestive heart failure. I may have 10 different codes associated with congestive heart failure. Well, we're going to decide to pick 2 or 3 of them. Guys, she's in for congestive heart failure. Again, I'm just using this as an example. She's in with congestive heart failure. Pick the appropriate ICD code representing the congestive heart failure situation. Why are you picking 3 of them? That's like double and triple billing.
Yeah. And that's incidentally, that's a really big problem for people on Medicare, because institutions that benefit from Medicare like to maximize what they can get from Medicare.
Now, I don't know what the percentage is, but when I was doing business analytics for enterprise, Medicare represented about 60 to 70% of revenue for most hospitals. So that's exactly what it is.
Yeah.
If I'm doing the coding game for Medicare, it's all about the reimbursement.
Yep. Whenever something doesn't make sense, follow the money.
Good. That is a correct statement.
Yes. So,
Now, I
so
will
Rose,
say the good thing is that she had a good pulmonary specialist follow-up. And
thank
he
God.
basically said, you guys titrate the O2 yourself. You know what saturation is.
Sure, sure. All right. So Rose, if somebody is looking for a healthcare champion, are you available?
In Florida or by phone. Now, and I always say is I'm not licensed in all states.
Right.
I will not give medical advice. However, I can review records. I can establish, guys, these are questions that you can ask. This isn't what's really making sense.
Mm-hmm.
So I won't function as an RN because I'm not licensed in every state in that.
Right.
But as a patient champion, yes, I can act as a consultant to line up correct questions of saying, I see a lack of care coordination going on.
Mm-hmm.
Where's the care plan? These are the questions you can ask to partner with your clinician. Absolutely. But I always like to stipulate because, I'm not licensed in all states and all that. I'm not going to be your medical advice, but
Right.
absolutely a healthcare consultant.
Okay. So if people want to get in touch with you, Rose, what's the best way for them to get a hold of you?
Website, www.delphinehc, which is DELPHINEHC.com. And it's Delphine, as in we love fine healthcare.
Cool. All right, great. And I'm going to put your that domain in the notes for the replays, so people who are watching who might want to get in touch with you can can learn more about what you do and reach out to you if they think they might be able to benefit from having you as part of their team.
And we need more HC aware education presentations. And
Yes.
the response I've gotten from when I give presentations is very wide eyes and stunned silence.
Yep. So and what we may do is what the next time we get together, we'll borrow some information from one of your presentations and maybe give listeners access to a recording so that they can see what it is, the education that you're putting out, because it's
Yeah.
extremely important for people to be armed with this kind of education at this very point in time,
Yeah.
because we are suffering from a severe shortage of caring practitioners, people who know what they're doing. The healthcare environment is perilous right now.
Well, I would say competencies, skill competencies, because again, they're not learning in schools and they're not learning on the floors.
Yeah.
And people have to understand you can't have blind trust.
No. No. Unfortunately, as we pointed out, a lot of medical institutions do have financial motivations.
Well, I don't want to go that route.
Yeah, no, I understand, but
Yeah.
sometimes when money comes into the picture, then the best interest of the patient is not necessarily a priority, and so the family really does need to be educated and supported with the correct information so that they can advocate effectively for their loved one for the best possible outcomes.
And and I will just say one thing is there aren't autopsies going on. And by the way, I in my presentation I talk about Johns Hopkins did that study in 2016 that 250,000 people die every year from medical errors, hospital acquired infections and conditions in medical errors. But there's no ICD code for that. It's all a coding game. So if 250,000 people have been dying each year, that magically didn't go away with the practices that I'm seeing. The abhorrent lack of clinical competency.
Right.
People are dying from medical errors and hospital-acquired infections and hospital-acquired conditions, but it will never get coded as such.
No, of course not. Of course not. Well, Rose, I want to thank you so much for joining me today and imparting your wisdom to the good kids. And I hope that people will avail themselves of the wealth of information that they can find on your website,
Delphine.
delphinehc.com.
Delphine.
Delphine, Delphine HC.
Oh, do we have any questions? I don't want to shut everybody down in case there was any questions because I went on and on and on.
Not seeing any.
Okay.
But folks, if on the replay you happen to have any questions, you are welcome to reach out to me or to Rose, and we will get your answers for you. So I want to thank Rose Rohloff so much for joining me today, and I want to thank you, the listeners, for paying attention, and I hope you will share the Good Kids Club podcast with your friends if you find value in it. And we'd love to hear from you with any topics that you might want to hear in the future. My name is Tracy Lawrence, founder of Grand Family Planning, author of Dementia Sucks, and we will see you hopefully next Friday on the Good Kids Club podcast. Have a great
Have a great holiday.
Yes, you too. Take
Bye.
care.
Bye.